Thank you, Dr. Ho. I want to thank the CNTR for the invitation to come and give first keynote address. This is a topic that I am very passionate about, and I look forward to this engaging conference and a deliberative discussion. My talk is entitled Disparities in the Trauma Care System, the Impact on Patient Outcomes. So our objectives, we are going to talk and describe the importance of eliminating health disparities within ACS, to describe the structural drivers that lead to health inequities within acute care surgery, to then describe disparities within the pipeline to become an acute care surgeon, and then to describe disparities within each link of the trauma care system. I have no disclosures. So the 2020 U.S. population is more racially and ethnically diverse than it was in 2010. And as we look at America, the face of America is changing. So we were a country that was 87% Caucasian in 1950. But by 2050, that number will drop to 47%. In fact, 90% of the U.S. population growth between 2010 and 2050 is expected to come from minority groups. People of color are already a majority in 50 of the largest cities in the U.S., and 6 states have minority majorities, as you can tell by the graph. So immigration to the U.S. has tripled in the last 30 years, representing the largest continuous wave of immigration in U.S. history. So given the increased diversity of the U.S. population, migration, globalization, healthcare professionals really must be equipped to care and to provide care in a cross-cultural context. And so from the CMS, really, health equity is the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred primary language, or other factors that affect access to care and health outcomes. And so the why is important. Why are we focused on eliminating disparities? Why are we focused on health equity? Well, we're going to briefly talk about it from an economical perspective, from a quality perspective, all in the effort of achieving surgical excellence. And so the business case for racial equity is that there is a potential economic gain of about $135 billion per year if racial disparities in health are eliminated. It's $93 billion in excess medical care costs, $42 billion in untapped productivity. In fact, the U.S. stands to gain $8 trillion in GDP by eliminating racial inequities by the year 2050. From a quality perspective, we know that equity is one of the 6 domains of quality, but it's often the forgotten domain of quality. However, the Joint Commission now mandates that we have strategies for reducing health disparities, that we are screening patients for their social determinants of health, and that we are developing an action plan to address identified health disparities within our patient population. And for CMS, payment determination will be tied to mandatory reporting of social determinants of health. It's voluntary in 2023. It will become mandatory in 2024. And that payment determination that's tied to the mandatory reporting of your social determinants of health will take place in 2026. And so for the American College of Surgeons, the highest priority is surgical excellence. So health equity is fundamental to achieving surgical excellence. And so structural determinants of health inequities are really rooted in structural racism. Comes the drivers of health and can lead to poor health outcomes. Historical policies such as redlining really impact your social determinants of health. Individual bias, whether it's implicit or explicit, really leads to disparate care. So these drivers of health can really lead to increases in mortality, readmissions, and hospital-acquired conditions or health outcomes. So what is redlining? Well, discriminatory lending practices of the homeowners loan corporations during the 1930s really effectively excluded Black Americans from obtaining government-backed home loans. Here on the left is a map of Chicago in the 1940s. It was intended to guide banks and other mortgage lenders in deciding which parts of the city were safest for investment. So part of the map has the city's neighborhoods color-coded, with green being the least risky for loans, followed by blue and yellow. Neighborhoods colored red were deemed hazardous. The graph on the right shows that these neighborhoods were home largely to Black Americans, other people of color, and ethnic minorities. So a neighborhood's racial and ethnic makeup was a key factor in whether its residents would get home loans. Black people who lived in the red colored areas would be unlikely to receive loans and thus would be unable to buy a house, even if they had good credit. Advance the slide if you can. Yeah. The redlining practices of the 1930s really contributed to what we're seeing today, increased rates of firearm violence, namely through the preclusion from homeownership, poverty, poor educational achievement, and concentration or segregation of Black communities. Yep. And so we, in this particular study, we evaluated the association between neighborhood-level racial segregation, socioeconomic factors, and life expectancy in the U.S. And found that highly segregated neighborhoods were associated with a statistically significant lower life expectancy by 4 years. The residential segregation really is a key structural driver of racial inequities. But we see this, that's the historical policies, but what about bias, right? So bias is another structural determinant of health. So about half of medical students and residents believe that Black patients felt less pain when compared to whites. Most healthcare providers appear to have implicit bias in terms of positive attitudes towards whites and negative attitudes towards people of color. We see it in our residency training programs and fellowships. We have found in our work, the proportion of applicants, matriculates, and graduates of our training programs have remained significantly low and unchanged. And attrition has remained significantly higher for underrepresented minorities. There's been a decline in Black and Hispanic applicants, matriculates, and graduates. When we look specifically at the surgical critical care fellowships, we found a disturbing trend. Next slide, please. But there has been a decline in Black and Hispanic applicants and graduates of our surgical critical care fellowships. So why is that? So this is the ACGME data, which looks at the number of graduates dismissed by specialties stratified by race and ethnicity. Surgery is on the bottom. Green represents African American trainees. So as you can tell by the graph, our trainees are being disproportionately dismissed from training programs 6 times the rate of white counterparts. It's not just general surgery training programs. We are seeing this trend in our surgical subspecialties, where Black residents are at a disproportionate risk for attrition and unintended attrition. Orthopedic surgery had the highest attrition and unintended attrition for our Black residents. And so if you look at the figure on the left, which is a relative risk of the different surgical subspecialties, it is stratified by being female, underrepresented minorities, and Black and African American trainees. So the comparison group for female residents was male residents. For underrepresented minority residents, the group of residents who were not underrepresented. And for Black residents, the comparison group were white residents. And you can see the disparities clearly. And so our Black doctors are being dismissed from training programs at far higher rates than white residents. And so Hughes and colleagues wanted to determine the national prevalence and sources of discrimination based on race, ethnicity, and U.S. general surgery residency programs to identify factors associated with discrimination and to assess its association with resident wellness. And so the overall prevalence of racial and ethnic discrimination was 24%. When stratified by race, Black trainees had an overwhelmingly higher prevalence of discrimination at 70%, followed by Asians at 48% and Hispanics at 25%. Sources of discrimination included different standards of evaluation, denied opportunities, being mistaken for a non-physician, slurs, feeling socially isolated, and a multivariable logistic regression analysis in determining risk factors for discrimination. You were 20 times more likely to experience racial discrimination if you were Black, and 6 times more likely if you were Asian. And residents who experienced discrimination reported higher rates of burnout, thoughts of attrition, and suicidal thoughts. These findings are not just unique to our trainees. This study looked at surgeons, our colleagues, and really sought to identify common microaggressions experienced in the surgical workplace by racial and ethnic minority surgeons. Important to understand the lexicon when we talk about microaggressions, microassaults, so that conscious and intentional discriminatory actions, microinsults, so verbal, nonverbal, and environmental communications conveying rudeness and insensitivity that is very demeaning. Microinvalidations are communications that exclude, negate, or nullify the thoughts and feelings experienced by persons of color. And so here is a figure that just sort of gives examples of microaggressions within the workforce. Or, wow, you've really come a long way. You know, being like a Mexican, that is just, I didn't expect somebody to be so well educated. Oh, wow, that last name is different. How do I say that? Where is that from? Is English your first language? Where are you from? They would just not accept that in Texas. And so the findings from this study showed that the feeling of being a foreigner, not belonging, were more likely to experience by Asian and Hispanic surgeons, whereas environmental criminality, invisibility, low achieving, undesirable were more likely to be experienced by Black surgeons. And so this bias, not just in our training programs, but this bias, be it implicit or explicit, is also seen in how we treat our patients. So this is an article that was published in the Bulletin in 2021 by one of our colleagues, Dr. Jamie Coleman, who discussed what happened to her husband, who had gotten into a very severe, significant motor vehicle collision, presented to a hospital, and basic ATLS was not performed. There were no labs, there were no x-rays, there was not even an IV. There was a visual inspection, and he was then going to be discharged. High-speed motor vehicle collision, nothing was done. Bias, implicit or explicit, leads to poor health outcomes. And so studies have shown that 20% of civilian deaths are potentially survivable. That's 40,000 lives per year nationally. For the NASM report, there is a national movement to really achieve zero preventable deaths after injury and to minimize disability. And so we can do that by looking at every link in the trauma care chain of survival. However, I'm going to take you through each link and show you that there are disparities in each link that's contributing to poor health outcomes for our patients. We're going to start with bystander care. So this study examined the rates at which people suffering medical emergencies on public streets receive help from bystanders, how this varies across patient race and incident locations in 33 states. 80% of patients who received bystander support suffered non-cardiac symptoms, bleeding, wounds from a traumatic injury. And this graph shows the predicted probabilities of bystander support. And as you can see on the left here, yellow would be Caucasian patients, and blue would be African American patients. As you can see, Black patients are less likely to receive bystander support. And when you look here at the table C, patients with a traumatic injury were 2 to 3 times more likely to receive bystander support. However, Black patients were 57% less likely than white patients to receive bystander support. So patients in the most disadvantaged counties were least likely to receive help from a bystander. And when combined, patient race and local socioeconomic disadvantage really create these substantial disparities in access to bystander support. You can imagine this is the first link in the trauma care chain of survival. About 1 in 30 Caucasian patients in high-density counties with average socioeconomic levels receive bystander support compared to about 1 in 260 Black patients in high-density socioeconomically disadvantaged counties. We're going to skip pre-hospital for now. We'll get right back to it. We're going to go right into the hospital definitive care. So Dr. Hayter evaluated the current literature on the association between trauma mortality and race, insurance status, and socioeconomic status between April 1990 and October 2011. And found that uninsured trauma patients had higher mortality rates than insured patients and worse long-term functional outcomes. And overall, the data showed that minority patients have worse trauma outcomes than Caucasian patients. Patients treated in hospitals with higher percentages of minority patients had significantly increased odds of mortality compared with hospitals treating primarily Caucasian patients. So we wanted to look specifically at thoracic trauma, particularly those patients with rib fractures. There is some data to suggest that rib plating or rib fracture fixation offers the a benefit of improved respiratory mechanics, improved pain control and severe chest wall injury by decreasing the time on the vent, time in the ICU, overall hospital length of stay. We wanted to see if there was an association of race and insurance status on management and outcomes in patients with rib fractures using the 2015 and 2016 TQIP database. What we found was that Black and Hispanic patients were less likely to undergo rib fixation, and that Black, other non-Caucasians, and Hispanic patients were less likely to receive an epidural. When you look specifically at traumatic brain injury, this is the data from the Los Angeles County database from 1998 to 2005. We found that uninsured African American and uninsured Hispanic patients with TBI had an increased risk in mortality compared with their insured counterparts, and that compared with uninsured Caucasian patients, uninsured Asians and uninsured African American TBI patients demonstrated a higher risk in mortality. Look at rehab. So elderly patients with TBI have poor functional outcomes. So we know that physical therapy and rehabilitation are essential in improving long-term outcomes in this population. So because disparities in care have been demonstrated among patients with isolated TBI, we sought to evaluate the role of trauma center designation and the association of race and insurance status with disposition to rehab centers among elderly patients with TBI using the 2014-2015 National Trauma Data Bank. What we found was that there was significantly less Black and Hispanic patients that were being discharged to rehab. In fact, on logistic regression, Black and Latino elderly patients with TBI were less likely to be discharged to rehab. In fact, they were 1.5 times less likely to be discharged to rehab, and Hispanic TBI patients were 1.7 times less likely. Asian elderly TBI patients at level 1 hospitals were more likely to be discharged to rehab centers if they had private versus non-private insurance. So let's get back to the pre-hospital link in the trauma care chain of survival. This study sought to determine the relationship between pre-hospital analgesia administration and trauma patient characteristics, including age, sex, race, and severity of pain. Now, pain score and pre-hospital time were both significant predictors of analgesia administration, with higher pain levels and longer pre-hospital times, resulting in increased administration of pain medications. In the multivariable logistic regression analysis, adjusting for race, sex, age, pre-hospital time, heart rate, and pain score, this finding was the same. However, African American and Hispanic patients were less likely to receive analgesia regardless of whether a pain score was recorded. About transport to a level 1 center or to a verified center. We know that transport of our trauma patients by EMS to definitive care facilities is associated with a significant reduction in preventable deaths and injury-related mortality. But we still have disparities in access to trauma centers. This study by Dr. Carr and his colleagues found that 309 million people in the U.S. in 2010, about 30 million lacked access to trauma care. Areas with higher income were significantly more likely to have access, as were major cities and suburbs. Areas with higher rates of uninsured patients, Medicaid and Medicare eligible patients, were less likely to have access. Being in rural America was associated with significantly lower access to trauma care. So it's not always just about race and ethnicity. Tang and colleagues examined geographic access to trauma care according to race and ethnicity to determine whether residential segregation and neighborhood poverty were associated with disparities in Chicago, Los Angeles, and New York City. Now, in defining a trauma desert, this was defined as patients injured more than 5 miles away from a trauma center, found that most Black majority census areas were more likely than white majority areas to be located within a trauma desert in Chicago and in Los Angeles. And after adjusting for poverty and race poverty interaction effects, similar findings were found in New York City. So the findings from this study really was sort of the first step towards informing a proper design and infrastructure needed for a more efficient and equitable trauma system. As we know, access delayed is access denied. 7,600 deaths per year really could be prevented through improved access to definitive care. We still see not only disparities in access to care, but we see disparities in the transport of trauma patients to trauma centers. And just looking at data in New York, approximately 200 trauma patients per year are transported to Bellevue from non-trauma centers. The total number of trauma patients transported to non-trauma centers within the state of New York or even within the city of Manhattan is really unknown. And disparities in the transport of trauma patients to trauma centers within New York are unknown. So previous studies have really demonstrated a marked survival benefit when our patients who are injured are transported to a trauma center versus a non-trauma center. No study really had evaluated the factors that influence the decision to transport injured patients to trauma centers. And so we wanted to look at this, to look at the disparity in the transport of our critically injured patients to trauma centers utilizing the National Emergency Medical Services Information System, or NIMSIS. This is a retrospective review, 2018 to 2019, looking at data from the National Association of EMS Data Officials, particularly the East region, with the final transport destination recorded. Patients with an injury and a final acuity designated by EMS as critical or emergent were included. And those who were dead on the scene had a final acuity by EMS listed as low, or patients with missing data were excluded. The key findings from this paper that 44% of critically injured patients are not being transported to trauma centers by EMS. 23% of critically injured patients designated as meeting CDC field triage criteria are not being transported to trauma centers by EMS. And 25% of critically injured patients with unstable vital signs are not being transported to trauma centers by EMS. When you look at it at gender, critically injured women are 19% less likely to be taken to a trauma center compared to critically injured men. And critically injured women with unstable vital signs were 26% less likely to be taken to a trauma center compared to critically injured men with unstable vital signs. This is the largest study really demonstrating an association between gender disparities and the transport of critically injured trauma patients to trauma centers, despite the availability of standardized national field triage guidelines. And so there are socioeconomic factors that underlie access to trauma centers. The limitations of our preliminary studies really are sort of a lack of complete data on race and ethnicity status, and only data from the East region, which includes 12 states, inclusive of DC. So the challenge really is understanding factors that determine sociospatial disparities that can inform interventions at both the policy and system levels, really to mitigate the disproportionate deaths experienced by minoritized populations from trauma. And so we're going to study that. I'm very excited to be the PI on this R01 grant, looking at health equity in emergency trauma care and analyzing the disparities, particularly in the pre-hospital emergency trauma care system. As we know that the pre-hospital stage of care is a crucial link to getting patients to a definitive care facility to be treated. And so we have to look at it. We have to look at it with respect to availability to EMS, with respect to response time of EMS, scene time, transportation time, the decision to transport to a trauma center versus a non-trauma center, and the total pre-hospital time to see disparities exist and where and what we can do about it. So given the substantial interaction between race and socioeconomic status, we really believe that the social determinants of health can explain these disparities in the pre-hospital phase of care. And so, in summary, we've described the importance of eliminating health disparities within acute care surgery, described the structural drivers leading to health inequities within acute care surgery, described disparities within the pipeline, and looked at each link within the system. And so, in describing the importance of eliminating health disparities within our field, we talked about it from a quality perspective, mandated by Joint Commission, payment determination tied to mandatory reporting. We discussed the importance from an economical perspective, where there's a potential economic gain of $135 billion per year if racial disparities in health are eliminated. Because quality care is equitable care. This was a lunch session at the AAST last year. Dr. Knowlton took the lead on this, and Dr. Cow here is in the audience, one of the key authors of this paper that was published in TSACO. We need to begin developing what are these health equity metrics, because what's coming down the pipeline is that it's going to be linked to verification. So we need to get ahead of this. We describe the structural drivers leading to health inequities, poor patient outcomes within acute care surgery. Slide, please. Again, structural determinants of health inequities are rooted in structural racism, which become the drivers of health, leading to poor health outcomes. We discussed the historical policies of redlining and how that impacts your social determinants of health and individual biases, both the provider level as well as bias that we see within our resident and fellowship training programs can lead to desperate care. And again, leading to increased mortality, readmissions, hospital-acquired conditions, all poor outcomes. Next, please. We describe the disparities within the pipeline to become an acute care surgeon. Slide. And then we describe disparities within each link of the trauma system. In bystander care, the pre-hospital care, within the hospital, and rehab. Bias, availability, and access to care. As an equitable trauma system really is needed to achieve zero preventable deaths for all patients. And there can be no progress on health quality without progress on health equity.